So we've known for decades now about the mortality gap for people with serious mental illness. And we also know from research that we've done more recently that a large driver of that is cancer, and in particular, lung cancer. And what this paper does in particular is take a really deep dive look into what is it that's causing that inequity in the diagnosis, the prevalence and the management of lung cancer. And without knowing what it is that's driving the problem, we can't know how to fix it. What we learned was that an inequity persists in both the diagnosis and the management of lung cancer for people who have severe mental illness. We learned that some of the drivers for that are the prevalence of smoking, which is much higher for people who have severe mental illness, and also about deprivation. So a very high proportion of patients who have serious mental illness live in some of the most deprived areas of South East London. And those factors can work together to increase the prevalence of cancers and lung cancer in particular.
People with severe mental illness tend to start smoking earlier than the general population, and when they do start smoking, they tend to start smoking harder and longer. They'll extract more tobacco, and they're absorbing more of that harm, the smoke that causes the harm, into their lungs.
I can't see it because I can't read it. Sorry, yeah. I can't read it.
Referral doesn't equal access for patients with serious mental illness. So there's something here about the pathway being quite leaky. That's partly about access to the pathway in the first place. But a lot of it is about retention once you get into the pathway itself.
People didn't know what was wrong with me. I was passed from pillar to post. They seemed, it was like it was an inconvenience to their day. That's what it felt like. And they won't give you they just write you a letter, and then it would take ages to get to me. They won't phone me, and then what they'll do, another thing as well, what they'll do, they'll ring your phone 3 or 4 times, like let it ring, and that's it. And to them, they've tried.
Joining up the puzzle for people was like really important, so that they didn't miss future appointments and that they had other people to talk to. Following up on all these individual tasks can be really difficult to achieve, but I think what you have to look is the longer term impacts.
Certainly in South East London, our population of people with SMI is younger, 54 and under, whereas the national lung cancer screening programme starts at 55. So it's not picking up this whole cohort of people who could be picked up early. We wouldn't accept that inequality, we wouldn't accept that mortality gap for any other diagnostic group.
So small things that could really make a difference tomorrow would be improving our communication, making it really clear and concise and done once. Employing navigators, care navigators within pathways, which already exist, so the model is there, it needs to be expanded. Improving data sharing and supporting patients at key points of drop-off. So where we know that patients are likely to disengage from the pathway, providing extra support at that key point.
You can do something really grand and bold and big and expensive, but also you can do something small within your own service as well. Even just educating yourself a bit about SMI, the additional burden that these people have living day to day, and how you can better support within your service is a step you can take to try to help someone.
The pathway isn't working for people with SMI. If we don't get this right, people with severe mental illness will continue to die 15 to 20 years earlier than people without. And I don't think we can accept that as a society.